Setting up an antibiotic stewardship program. Programs will vary according to the type of facility. With larger facilities that have more resources, we'll be able to put together bigger teams and provide a different kind of service. However, there are general principles of setting up a program which apply, and that's what's going to be covered in this lecture. What every single antibiotic stewardship team needs is a champion. If there isn't one person who is dedicated to the cause of improving antibiotic stewardship in their hospital, then things are destined to fail. The team makeup will depend on the size of the facility and which team members are available. The ideal team, which is only usually possible in a large hospital, will have a clinical pharmacist, will have a number of doctors, that would be infectious disease specialists and microbiologists, as well as the primary doctor caring for the patient at the time. Nurses should always be involved, including infection and prevention control specialists, and the nurse primarily caring for the patient. And the hospital management team also need to be involved in antibiotic stewardship. Clearly, this type of team is only possible in very large institutions. The size of your team. In a very small institution, the size of the team might be just one person. It might be a dedicated clinical pharmacist who's pushing the agenda of antibiotic stewardship. In a large tertiary centre, it might be a very large team containing all the people that were described in the previous slide. Either way, it's possible to make an impact. Here are a list of antibiotic stewardship activities that the team can undertake. They can be involved in education, they can write guidelines and do chart reviews, they can do dedicated ward rounds, be involved in monitoring and evaluation, and critically they need to be involved in feedback. We're going to go through each of these in turn. In terms of education, the first thing you can do if you start a team is encourage people to take this course. You could also encourage them to use the ASP app, which is available in the Google and Apple stores and is an accompaniment to this course. You can promote the use of guidelines. You can promote the removal of intravenous lines and the removal of catheters, and also prompt intravenous to oral switching. Hand washing is a key component of antibiotic stewardship, and this should be promoted at every opportunity. You may be able to get involved in writing local guidelines, particularly if you have access to the local antimicrobial resistance data and local drug availability. And you can use readily available resources such as national guidelines and international guidelines. If you're not sure where to look at this website, fitza.coza, which has a number of national and international guidelines in infectious diseases. You can be involved in chart reviews. Think of the 4 Ds. Is the patient getting the right drug at the right dose for the right duration with the right mode of delivery? And you can do chart reviews to see how you're getting on. You can also look at charts to see if there are overlapping spectrum of activity for antibiotics that are prescribed. And if you have access to laboratory results, you can check that the appropriate antibiotics are being given when looking at the sensitivity profiles. If you have a large enough team and enough resources, you can do dedicated antibiotic stewardship ward rounds. It's important to involve the team who's caring for the patient. That's the doctor and the nurse on the ward who are primarily responsible for the patient. Go from patient to patient and ask them to present each case. Ask them to justify the antibiotics, justify if the patient has an intravenous line, and justify the use of a urinary catheter. Based on what they tell you, you can then discuss the case and you can provide feedback at the end. This can be a very effective way of including all caregivers in antibiotic stewardship, improving the care for the individual patients that you see, as well as providing education. Antibiotic stewardship should always involve monitoring and evaluation. You can look at local prescribing data and patient safety data, such as rates of drip site infection, rates of C. diff infection, and rates of adverse drug reactions. You can also do quality audits. The final aspect of antibiotic stewardship is giving feedback. For example, you can feedback on the trends in antibiotic prescribing in your institution and the trends in healthcare-associated infections. You can report on the reduction in intravenous line use and the reduction in intravenous urinary catheter use. And you can present quality improvement audits. In summary, size and makeup of your antibiotic stewardship team depends on the size of your facility and the resources available. But all successful teams will have a champion. If all you're able to provide is basic education, this can go a long way. It's always important to improve infection control, which is a key pillar of reducing resistance. And remember to monitor and evaluate, and always give feedback.